Good afternoon, and welcome to the Johns Hopkins 30-minute COVID-19 briefing, where we provide live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. For the next half hour, we'll focus on what you need to know right now about the COVID-19 pandemic and public health responses. As part of this briefing, we'll have an opportunity for live Q&A with our experts, and we'll be offering these 30-minute briefings regularly on Fridays at 12 p.m. I'm Dr. Lainie Rutkow, a professor at the Johns Hopkins Bloomberg School of Public Health, and I'm part of the leadership team for the Johns Hopkins Coronavirus Resource Center. We'll be providing answers in real time today, so please submit your questions in the box at the bottom of your screen. Today, I'm joined by two guests. Dr. Jennifer Nuzzo is a senior scholar at the Johns Hopkins Center for Health Security and an associate professor at the Johns Hopkins Bloomberg School of Public Health. Jennifer will give us an update on the public health implications of the COVID-19 data. Dr. Bill Moss is executive director of the Johns Hopkins International Vaccine Access Center and a professor at the Johns Hopkins Bloomberg School of Public Health. Bill will give an update on COVID-19 vaccines. I'll now turn to each of our speakers for a brief overview. Jennifer, I'd like to turn to you first. Since we were last together, COVID cases and fatality numbers have continued to soar, breaking records sometimes on a daily basis. And we now know that there are new variants of the virus that are more easily spread. Can you talk us through the major trends that you're seeing? Jennifer, I think you're muted.
Thank you, Lainie. Yes, we continue to see worrisome trends in terms of our numbers, in particular the case numbers, worrisome increases. Our average daily case count continues to exceed 200,000. And this is given the fact that it will likely be weeks more before we see the true effects of holiday gatherings, Christmas and New Year's. What we've noticed is the pace with which we're adding cases really has accelerated now to the point where the United States is accumulating an average of 1 million cases every 4 days. So this is quite clearly a worrisome trajectory to be on. More than 20 states have seen their highest case count in the past 2 weeks. So many states really having these trends. And of course, the discovery and observation of these new genetic variants and the predominant concern about these variants is the potential for increased transmissibility obviously heightens our worries that the already accelerating case numbers that we're seeing were these variants to become more dominant in the United States, that will further accelerate our case growth. Deaths is also another area where we're having really quite troubling news. Deaths continue to increase across the country, breaking records from even pre-pandemic times when we were much more, less prepared to deal with the cases. Yesterday, unfortunately, was an all-time high. More than 4,085 Americans died from the coronavirus yesterday, and that's the highest number we've ever seen on a single day. I feel like as we've done these briefings each week I say that we've broken a record, and unfortunately we have yet broken another record this week. 13 states have had their highest daily death count in the past 2 weeks. So that's just going to show that these recent numbers are even more worrisome than they have been. In terms of the pace of the deaths, the United States reached 300,000 cumulative deaths on December 14th, and then added 50,000 more. So we reached 350,000 deaths less than 3 weeks later. If these trends continue, we will expect to see 400,000 total deaths by the end of January. Also, some worrisome concerns with respect to testing. Test positivity in the United States is now more than 13%. This is the nationwide figure. This percentage is up more than 2% compared with 2 weeks ago. This is worrisome, one, because with positivity this high, we are likely missing many infections. And this means that we're not only not counting them as cases, but we're also missing opportunities to stop them from transmitting the virus to others simply because people may not be aware that they're infected. This will make the pandemic worse. And it's really urgent that we do more testing to keep pace with the acceleration of cases that we're seeing. Unfortunately, our testing data also shows us that testing over the last month has essentially plateaued. So while the case numbers have been accelerating, the number of daily tests largely has stayed the same, which is why we're likely seeing these high positivity. But it also means that all of those kind of earlier months trends where we were doing more and more tests every single day, that has really stopped as of late. And that's really one area where we need to continue to do work. We've heard some states have, as they've prioritized the rollout of vaccine, have actually scaled back on their testing operations. That's clearly not ideal given the case numbers that we have. And just because we're rolling out vaccine, that does not in any way obviate the need to continue to do more and more testing. These trends are playing out in multiple states. So, 14 states we've seen have had a substantial increase in test positivity in the last 2 weeks. And with this many states having these trends, that's why these national numbers are the way they are. Hospitalizations are also increasing nationwide and setting records in key states. We're seeing that the hospitalizations are increasing across the U.S., but the pace of the increase has been greatest in the southern United States and western United States. We were looking at the number of states that the hospitalizations on a per capita basis and found that 8 states are now reporting more than 500 hospitalizations per million residents, which is quite a high number. So worrisome trends there as well.
Thanks, Jennifer. Before I turn to Bill, I want to remind our audience, please submit questions for Jennifer and Bill in the box at the bottom of your screen. We'll move to Q&A right after we hear from Bill. So Bill, we now have 2 vaccines with emergency use authorization in the US and a small number of individuals who are already fully vaccinated, meaning that they've received their second dose of the vaccine. Can you talk us through the latest developments?
Yes, Lainie, and a lot has happened since we last spoke on December 18th, which was when the Food and Drug Administration issued the emergency use authorization for the Moderna vaccine. It was 1 week prior to that, on December 11th, when the EUA was issued for the Pfizer vaccine. And again, it's worthwhile pausing and reflecting just how remarkable this is, that we are, here a year into the pandemic and have a very highly protective vaccine. So that is a remarkable achievement. Globally, there's one other vaccine that has been granted full approval, although not in the United States. That's the AstraZeneca University of Oxford vaccine. That's a chimpanzee adenovirus vaccine. But there are 7 other vaccines seven other vaccines in earlier limited use, 20 vaccines candidates in large trials. So there's still a large pipeline of vaccines. I think one of the ones we're excited about in the United States, I think, the AstraZeneca vaccine, we still need to learn about the efficacy in relation to the doses, but there's a lot of hope that that vaccine will play a major role globally, along with some of the Chinese inactivated vaccines, and we're beginning to get more information on their efficacy. I think there's a lot of excitement potentially about a Johnson & Johnson human adenovirus vectored vaccine if it can be administered as a single dose. That would make the delivery so much easier. And just to highlight, the AstraZeneca vaccine doesn't require the very cold storage that the messenger RNA vaccines do. So the first point I want to make is that there's still a large pipeline of vaccines, potential vaccine candidates in the wings. So there's been a lot of attention paid to the rollout of the Pfizer and Moderna vaccines in the United States. The latest data that I saw from the Centers for Disease Control and Prevention, over 21 million doses distributed, but just under 6 million doses actually administered. So we're hovering around 30% overall as a nation in terms of getting the vaccine out. And obviously, there's been a lot of discussion around this. I think we are. We are behind, I think, on our expectations for getting vaccines into people, into arms where they are protective. I'll just address that briefly. First of all, just some of the I'll talk first about some of the components of a successful mass vaccination campaign, and then some of the reasons why this is particularly challenging with these COVID-19 vaccines. So I like to think of the 4Ds for a successful mass vaccination program. You have to have doses, be able to deliver them, you have to have demand, and you have to have data to be able to track who you're getting into the vaccines into. So in terms of doses, we knew that we were going to have insufficient supplies and that it was going to take time to scale up. There's been a lot of discussion around perhaps ways to extend the number of existing number of doses, and we just heard earlier today from the Biden transition team that they plan to release the federal stockpile, if you will, of second doses and try to get those out on the assumption that there'll be continued and sufficient vaccine supply to get the second doses into people. And just as a reminder, the vaccine efficacy data that we have for both of these vaccines comes from these large phase 3 trials in which people receive 2 doses, 3 weeks apart for the Pfizer vaccine, 4 weeks apart for the Moderna vaccine. And that's what the science tells us. The second D is the delivery. And, this is where I think we have fallen behind. To really do a successful mass vaccination campaign, you have to have adequate planning. You have to have an adequate vaccinator workforce, enough people to deliver the vaccines, and enough resources to be able to do outreach and community mobilization and communication around vaccines. And this is where I think we need to do better going forward. Obviously, you need to have the demand. And so there need to be public awareness campaigns. And we've talked before, about the demand for the vaccine. And we know that there are populations and people within the United States who are hesitant about getting the vaccine or mistrust it for various reasons. And lastly, we have to have the data, what we're doing, exactly what we're doing with the Johns Hopkins University Coronavirus Resource Center website and trying to track doses. But we need to do much more in terms of just kind of counting doses administered or distributed. We really need more detailed data on who's actually getting the vaccine and are we meeting our targets. So why is this particularly challenging? There are a number of reasons why this type of effort is even more challenging, I'll say, than some of the many mass vaccination campaigns that countries do for childhood diseases, such as for measles or polio. One is we're targeting adults, and we don't do as good a job in getting vaccines into adults. Secondly, there's been unclear target populations. We have high-level recommendations, for example, that healthcare personnel should receive the vaccine first. But even within that, that's a broad category of people. And so that's been unclear, and people administering vaccines have struggled with this to try to prioritize even there. And then, when to shift into the next phase or next group of people. We need to allow flexibility for that to happen so that we're not holding on to doses. Some states and healthcare facilities, for example, have struggled with an unclear number of doses that they're going to receive. So we need to make sure that the supply chain is more predictable so they can do better planning. And we also know that the current, vaccinators, if you will, that at healthcare facilities or at pharmacies, they're already overstretched in caring for people for the, with COVID-19, in doing the testing. And so we really need to expand our workforce to be able to get these vaccines out. The last thing I'll just touch on, Lainie, and Jennifer mentioned this, are the variants. And Jennifer mentioned certainly the concern about the increased transmissibility. And there are also some concerns about whether those variants may cause more severe disease. There's no evidence to support that, but also whether the current vaccines will be protective against these variants. And there's a lot of ongoing work to address this. We do not know the answer yet. Many people, including myself, think that the vaccines will be protective. It's certainly not going to be, complete lack of protection. I think they will protect against disease, but we still do not know. And there was a recent study looking at one of the particular mutations that is in both the UK variant, the South African variant. Looks like the neutralizing antibodies induced by the vaccine, by the Pfizer vaccine in particular, will be protective against this. But there's a lot of ongoing research right now, and I think we'll learn more in the next week or two about whether we expect these current vaccines to be protective against the variants. And I'll stop there, Lainie.
Thanks so much, Bill. I'm now going to turn to questions that are being submitted by our audience. And folks, please continue to submit questions. We're looking forward to answering them in the next few minutes. Jennifer, first question today is for you. And this picks up on something that Bill was just talking about a moment ago concerning this new variant, or in all likelihood, new variants of the virus that we're learning about. When people say that the new variant is more easily transmitted, what exactly do they mean by that?
Sure. Well, the evidence comes from a few different dimensions. For me, one of the more compelling ones is the finding that people who are infected tend to have higher viral loads. So the more virus you produce, the more possibility it is to transmit. They also look at the how dominant the strain has become in places where the surveillance has been ongoing, and for instance, in the United Kingdom and in South Africa, it has become the dominant strain in some areas. And then finally, they look at the growth of cases over time and sort of back calculate to figure out how they could have gotten from one point to another, and that also provides some evidence that it may that individuals who are infected may be producing on average more infections than the previously dominant virus did.
Thanks, Jennifer. Bill, question for you. Once someone has received either the Pfizer or Moderna vaccine, meaning 2 doses, so they're considered fully vaccinated, what do we know about the duration of their protection?
This is a very important question, Lainie, and unfortunately, we do not know the full answer to that question, just because there hasn't been sufficient time to follow people, and really learn the duration of protection. That's going to be something that we're going to be following very carefully, both in the phase 3 trials, which are still ongoing. People should understand that even though there was an emergency use authorization that by the FDA for both vaccines, that was based on preliminary data from the phase 3 trials, meaning that they didn't complete, obviously, the full 2 years of follow-up. So we'll learn more about the duration of protection from the phase 3 trials, and we'll certainly learn more as we vaccinate millions and millions of Americans about the duration of protection as well. I suspect, this is a guess, is that it's going to be at least several years, and it's possible that people may require a booster dose later on. I don't think the protection is going to be as short as 1 year or less than that, but we really do not know yet.
Thanks, Bill. Jennifer, follow-up question for you about these new variants that we're seeing. Given what we know so far, if folks continue to adhere to social distancing measures, masking, what impact do you expect these new variants to have on trends?
Sure. So at this point, I think what the new variants change for us is just, and it's not really a change, I think it just highlights the urgency of acting swiftly to try to control the spread of this virus. But the way that we do that has not changed. So the same recommendations of, social distancing and mask use and, avoiding places that are most likely to result in transmission, those remain. It's just now that we see the potential for this virus to mutate, which we've known about. It's just that these are, I would say, the first two mutations that have been particularly that have some kind of functional difference in the sense of increased transmissibility. That just suggests that there is a need to act more swiftly to control the spread so that we don't see cases grow more quickly, so that we can continue to roll out efforts to vaccinate people as the way to protect them. And we don't want the spread of this virus to outpace those efforts even more.
Thanks, Jennifer. And no surprise, additional question for you about these new variants. What's your take on the state of the science, so the evidence base in terms of increased transmissibility of the new variants?
I would say there's increasing evidence of it. It's there. Many groups have looked at this in different ways, and I think from what they're seeing, it is compelling. To date, it doesn't fully answer all questions. Some of the surveillance, there are some conclusions that are derived from the data rather than directly observed. But I think it's a reasonable assumption at this point that what we are seeing is potentially an increased possibility for transmission. It doesn't fully explain alternative hypotheses, doesn't fully wave away alternative hypotheses, but I think the evidence as of now is more compelling than it was initially.
Thanks. And Jennifer, a question for you about post-holiday surge. So when would you expect to see a peak that we can likely attribute to the holidays?
So I think it's going to be a minimum of 3 weeks to a month. What we keep seeing is that often the surges happen a bit silently at first, meaning that they are people who travel, maybe people who are healthier and not likely to, be the ones that develop the more severe symptoms, but they could still get it and pass it on to others, and that could take some time. It becomes more obvious when we start seeing people who become sick enough that they absolutely are going to get tested. We start seeing changes in hospitalizations, et cetera. So I give it a fairly long runway, probably at least a month before we start seeing, and it will continue past that time.
Thanks, Jennifer. Bill, question about what we're seeing now in terms of priority or attempt to prioritize different at-risk populations for vaccination. What do you feel about what we're seeing so far, and how will the attempts to prioritize at-risk populations hold up when we have actual mass distribution?
Yeah, so I first of all, we knew that these vaccines were going to be a scarce resource, and we needed a prioritization process. And so I'm certainly on board with that, and there have been a number of groups, including the Center for Health Security, that thought through at least ethical principles and guiding principles on setting prioritization processes. Obviously, implementing this is more challenging than some higher level thought on this, but we needed that higher level thought. What we don't want to have happen is the prioritization process really impede our ability to deliver the vaccine. And Jennifer and I were just chatting briefly about this. I think we need a prioritization process. It's going to get more complex as we move from healthcare workers and residents and staff of long-term care facilities into, certainly with people with high-risk individuals with comorbidities. That's going to be a complex process. Having a strict age cutoff, say, for example, individuals over the age of 65 years, that's a little simpler to implement, but the comorbidities becomes more challenging. Who's an essential worker is a very complex, challenging question, and we're not going to be able to achieve perfect equity here. What I don't want to have happen, as I said before, is have that prioritization process really delay our ability to administer vaccines. But we also don't want a situation of great inequity, where people with power and privilege and wealth are able to kind of cut the line, if you will. So we need to be able to maintain those broad prioritization groups without making the perfect the enemy of the good.
Thanks, Bill. Jennifer, question for you. So we're seeing in Maryland that teachers have been added to the next priority group for vaccination. So given this, but also thinking about the many moving pieces, including the new variants, what are your thoughts about children going back to school?
I mean, I continue to believe that it is possible to safely bring children back to school. The risk is always more about the teachers and the staff who than children who have. So far, the data has continued to show that this virus is doesn't affect children nearly the same way it does adults. So I think given the societal role that schools play, that an idea of vaccinating teachers to allow them to return to the classroom and feel more safe being there, I think that is a goal that is a worthy one. I think we continue to see data from other countries and other places that it is possible to reopen schools and to do so safely. It requires resources, but it also requires a commitment to, allow schools to be the first to open and the last to close. But that might require closing other things to keep case numbers to the point where we worry less about outbreaks happening in schools.
Thanks, Jennifer. Bill, if we assume, and this is completely theoretical, but if it were to turn out that one of the variants is not, or vaccines are not effective or as effective, again, for one of the new variants, how rapidly could the available vaccines potentially be adapted to become more effective?
Now, this is a really interesting question, and I think it ties into the technologies that we're currently using for vaccination, both, and I'll focus on the messenger RNA vaccine, but I think this applies as well to the adenovirus vectored vaccines, such as the AstraZeneca or the Johnson & Johnson. So the way these vaccines work is that we are basically inserting the genetic code or instructions from of this basically part of the spike protein of the SARS coronavirus 2, and allowing our cells to make that protein and our immune system to respond to it. It's pretty straightforward to get, for example, the genetic sequence of one of these new variants, let's say, assuming that it bypasses the current immunity, and modify the vaccine, the messenger RNA vaccine, so it really encodes for that new spike protein, if you will. So that one of the wonderful things about this messenger RNA technology is its adaptability. So that could probably be done. I've heard estimates 1 to 2 months, and you could have a new vaccine. The issue is going to be on the regulatory side, and oftentimes the standard practice is when a modification is made to a vaccine, it's considered a new vaccine and has to start all over again in terms of its going through the trials and the regulatory process. So I think and I'm uncertain about how that would play out, whether, for example, the Food and Drug Administration, in the midst of a terrible pandemic, would basically allow for shorter period of time to evaluate that modification to the vaccine. That's, I think, where the real delay could be, but perhaps not necessarily.
Great. Well, thank you, Bill. We're at 12:30, so I'm going to wrap up. I'd like to thank Jennifer Nuzzo and Bill Moss for joining me today and give a big thank you to everyone who joined us, and especially to those who submitted questions for Jennifer and Bill to answer. This briefing will be archived and available on coronavirus.jhu.edu. And as a reminder, we'll be offering regular 30-minute briefings on Fridays at 12 p.m. In each briefing, we'll focus on what you need to know right now about the COVID-19 pandemic, and we will have live Q&A with our experts. I'll look forward to seeing you at our next 30-minute briefing. And until then, thanks and stay safe.